what you can have. Number one regret, no take backs. The hole in your chest, that's payback. Payback, yeah, you better take that. You could call me selfish or critical.
Moving forward with the National Vector-Borne Disease Control Program strategies, we have already covered about the early diagnostic modalities. In the previous module, we have already discussed about the prompt treatment modalities, where we talked about the ACT-SP, ACT-AL, and the protocol for chloroquine and primaquine in Plasmodium vivax. Now let us talk about some other strategies under this program, 3, 4, 5, 6, and 7. Next strategy is the chemoprophylaxis. The chemoprophylaxis is a primary level of prevention. It is primary prevention. Why do we call it as primary prevention? Because chemoprophylaxis is technically given to those people who are on long-term duties to endemic areas where they are prone to malaria. See what happens in the endemic areas, although we had discussed in the first module in malaria that in the endemic areas people are living. So different people will be living in endemic areas. There is a baseline level of malaria exposure which is happening to everyone, and because of a very small baseline malaria exposure, there are chances of building up the immunity. Based on this model, I think you would be able to appreciate better if you just replicate the COVID-19 system that we have in India and understand that there is a lower level of infection which is already happening, which may cause boosting of immunity rather than causing the disease. So that phenomena of immune covers that we have in a country like setting like India is what has happened in malaria also. So in malaria endemic areas, there is immunity in the area. Now people coming from outside, they will be most vulnerable who are traveling to malaria endemic areas. That means malaria coming from malaria endemic areas is not because of people who are living there. It is because of children who come to that area, travelers who reach that area, or people who are posted from outside. So therefore, it is important to give them chemoprophylaxis. Chemoprophylaxis can be of two types. We can have a short-term chemoprophylaxis, or we can have a long-term chemoprophylaxis. The short-term or a long-term chemoprophylaxis. The short-term chemoprophylaxis is for travel less than 6 weeks, and long-term is for travel more than 6 weeks. The drug of choice for short-term chemoprophylaxis is given as doxycycline, given at the dose of 100 milligrams. It is given as daily tablets. And for more than 6 weeks travel, we have to give the drug of choice is mefloquine. Mefloquine given at the dose of 250 milligram tablet, given as weekly tablets. In case of mefloquine, in case the person is traveling for more than 6 weeks, we should start mefloquine at least 2 to 3 weeks in advance. 2 to 3 weeks in advance or before the travel starts. And if we talk about doxycycline should be started at least 1 to 2 days before travel. 1 to 2 days in advance of the travel or before travel. Both doxycycline and mefloquine, they should be continued for. These both should be continued for 4 weeks after the travel is over, So for a month, the chemoprophylaxis for malaria has to be continued in case we want a good full protection. So that is your strategy number 2, that is about the chemoprophylaxis, that is doxycycline, or we can have the mefloquine. Next, to discuss about these strategies 4, 5, 6 and 7. The fourth strategy that we are going to do is integrated vector management. So now you have treated the person, you have given the diagnosis, you have treated the person, even you have prevented people from getting malaria. But now we are going to prevent the whole population from getting malaria. How are you going to prevent? We have to do integrated vector management. Let us have a couple of discussions on IVM, that is integrated vector management. First MCQ, what is integrated in this? Integrated approach means everybody will be integrated, people, and we are going to attack all the stages of the mosquito. Integrated means all stages of mosquito development will be attacked in this. That is what is integrated vector management. In case, and because you're watching this video till now, I presume that you must have watched the video on entomology and where we have discussed about everything about mosquitoes. In case you have not, I would request you to stop this video here, go back to the other section of entomology and try to do the entomology, learn about the mosquitoes, because based on that understanding, you will be able to prevent malaria in the area and understand about the malaria nuances. Small things in malaria would be understood only if you know how the mosquito sits, how it reacts, how does it fly. So to kill a mosquito, you should know how the mosquito behaves with us. So let's learn about the mosquito first, and then we are going to come back to the integrated vector management in case you haven't. Now, continuing with the integrated vector management, there are 4 broad strategies in this, in the integrated vector management. The first strategy is something called as source reduction. Source reduction. Next strategy is what is personal protection. Third strategy is what we call as anti-larvals, and we can have anti-adult. So let's talk of the basic thing first, that is the source reduction. What do you mean by source reduction? Source reduction means to stop the source. So how to stop the source or to stop the water? So primarily speaking, if you are tackling malaria outbreaks in the area, now this is vector-borne disease control program. We are going to discuss everything about every disease, right? And this is integrated vector management. So you're tackling all the vectors at the same time, right? You remember that under the National Vector-Borne Diseases Control Program, all diseases are caused by mosquito except one disease, that is Kala Azar. Kala Azar is the only one which is caused by sandfly. So if you are having a malaria outbreak in the area, that means there is a lot of Anopheles. Anopheles, you remember from your entomology that it stays in which water? It stays in clean water. So that means for this area, for Anopheles, just for your knowledge purpose, you should know that what areas to clean, that is overhead tanks, roadside water collection. Roadside water collection, this is clean stagnant water you are targeting. In case there is a dengue outbreak is due to the Aedes mosquito, Aedes aegypti mosquito. You already know that what is the source for Aedes mosquito, that is artificial water containers. So you are going to tackle what all things? Empty tires, rooftop tires, and overhead tanks again, and coolers and fountains, and so all things for Aedes. These are artificial water containers. Please remember this word, it is water containers. And Anopheles is a clean stagnant water. In case there is Japanese encephalitis or a lymphatic filariasis outbreak, that means you are going to tackle with the Culex mosquito and the Mansonia mosquito, So in these cases, we have to take care. You have to keep it in mind that you have to take care of the large water bodies. You have to take care of areas where the drainage system might be blocked. So it is blocked drains. You also have to importantly take care in Mansonia and Culex about the paddy fields, which are large water bodies with standing water, paddy field area. So that is what is the source reduction. You have to stop the source. Next is MCQs you need to remember from personal protection measures. Personal protection measures, we are going to talk about the bed nets, or we can also have the mosquito repellents, or the coils and Odomos creams and all out and good night and so many stuff. MCQs on this. Bed nets. How many types of bed nets do you know? We know 2 types of bed nets. We can have a ITN or we can have LLITN. ITN stands for insecticide treated nets, or we can have a long lasting insecticide treated nets, right? So MCQs again on this. What is the insecticide in the insecticide treated nets? We normally use the government. You can use any insecticide. So normally the government of India is giving deltamethrin for use for impregnated. These are deltamethrin impregnated bed nets. Next MCQ, insecticide treated nets would roughly be applicable for 2 to 3 months. Usually we say 2 months only. And long lasting insecticide is for 5 to 6 months, double the time. Insecticide treated nets are given free of cost under the Government of India scheme to all areas with API more than 2 that are problematic areas. Long lasting insecticide treated are also given in many areas. This is a slightly novel technique but primarily reserved for very high malaria endemic areas, API more than 5. What is API? API stands for the annual parasite incidence. It stands for the annual parasite incidence. We will discuss about these indicators, monitoring evaluation indicators in time to come. But for right now, please remember that API is one of the most sensitive and most commonly and the best epidemiological tool based on which all our strategies would depend. I will have to say many times API. That is annual parasitic incidence. So these are 2-3 MCQs you need to remember about the ITNs, insecticide treated nets, and the long lasting insecticide treated nets. Next MCQ should be about the mosquito repellents. For mosquito repellents, you have various chemicals in it. So mosquito repellents, you will have various chemicals in it. We can have natural chemicals like lemongrass oil. We can also have citrulina oil. We can also have chrysanthemum oil. We can also have neem oil. So a lot of oils can be used which just throw away the mosquito. These are natural repellents. Or we can also use the chemical MCQ. The chemical which has been approved under the National Vector-Borne Disease Control Program is DEET, diethyl toluamide. Diethyl toluamide. It is the insecticide which is available under the National Vector-Borne Control Program, and that is approved for use as mosquito repellents. One question to you before we switch over to the next topic. What do you think? Think over this and tell me, what do you think All Out and Good Night, what are these? These are mosquito repellents or anti-adult? You must have seen advertisement in television that the Good Night and the All Out, there are arrows coming out of Good Night and they will go and they will hit the mosquito and the mosquito dies. In reality, do you think when you switch on Good Night or All Out, does the mosquito die? They don't die. These are all mosquito repellent. They just shoo off the mosquito. They don't kill a mosquito like the arrows. So please remember, all these Good Nights and all these things are mosquito repellents. So we have done source reduction, we have done the personal protection. Next, let's come over to anti-larval and the anti-adult measures. So if you talk about the anti-larval measures could broadly be classified into physical methods, chemical methods, or we can have the biological methods. Biological methods is one of your favorite answers. Every time I take a Viva and I tell which of the following are the best ways to control a mosquito, the best answer would be a fish. So anyways, that's the most common given answer. You think that to stop a mosquito, you need a fish every time. But anyways, let's discuss from MCQ point of view, which are the things you require. Physical methods. How will you kill a larva? These are anti-larval methods, right? We are discussing anti-larval methods. How will you kill a larva physically? How will you go physical with a larva? Don't go physical with a larva. But how are you going to slap the larva? Are you going to kick the larva, box the larva, or you can catch the neck of the larva and just strangulate it? Absolutely correct. That is what I'm telling you. PSM people are very intelligent people. They know how to strangulate a larva, and the larva doesn't even come to know that it was strangulated. What we use as MCQ, that is MLO. MLO stands for the mosquito larvicidal oil. Mosquito larvicidal oil. It is used at the rate of 200 liters per hectare. It forms a film over the water. This film over the water, so the larva cannot come up, it cannot breathe, and so it is asphyxiated. So we are actually strangulating or asphyxiating the larva. So this is one of the best physical methods. If you talk about the chemical methods could be broadly your favorite answer. Whenever we ask the student, tell me one of the chemical methods you know by which we can kill the larva, the favorite answer is so good looking color, that is Paris green. Paris green. Do you know that Paris green had been stopped somewhere after World War II because of toxicity reasons, but still you people are answering Paris green day in and day out. So I have to teach you Paris green, that it is no more used in many of the health programs, and in India we are not using. So Paris green actually is a stomach poison. In very rural areas, they might be using Paris green, but under the National Vector-borne, we have advanced to some newer larvicides. So Paris green is a stomach poison and it is a chemical which will cause larval death. The newer insecticide or the larvicide or the chemicals that you need to learn is Temifos. What is Temifos? It is an insecticide and a larvicide. It is given by the name of abate. Abate is also used at the rate of same answer like MLO 200 liters per hectare. Right? Next is one of more chemical measures which is again anti-larval. These are called as, this is something like a new thing. This is a prospective MCQ. Let's draw a 3-star MCQ over here. So the prospective MCQ which can be that these are insect growth regulators. So what is this new class that is IGR? See, do you wear clothes? Of course you must be doing. Does the mosquito wear clothes? No mosquito would wear a jacket or a shoe, right? Why doesn't the mosquito wear clothes? Doesn't it feel cold or something? No. God has given a permanent jacket to the mosquito. That is called as chitin. Do you have chitin? No. So that's where you strike the mosquito hard and you strike it complete. If you can replicate chitin somehow, you may have a chance of killing only the mosquito and therefore humans will not be affected by that insecticide. Right? That is what is insect growth regulators. They interfere with the development of chitin. They interfere with the development of chitin. And they actually stop the molding from pupa stage to the adult mosquito. They also mimic, they also not inhibit, they mimic the mosquito hormone. So now we have entered into the endocrine system of the mosquito. Mosquito hormones to inhibit adult maturation. So these are the effect of the insect growth regulators. So the examples of these you need to remember. Examples can be pyriproxyfen or diflubenzuron. So these are insecticide growth regulators. They mimic the mosquito hormones to stop the adult maturation, and they might also block the chitin synthesis and molding from the pupa to the adult stage. Apart from these, so that's all about the anti-larval. So what did you do in anti-larvals? We had the physical methods and the chemical methods. Next we come over to these, the biological methods. The biological methods would be your favorite answer. We can have the fish. What type of fishes are available for the biological methods? The fish is Gambusia, affinis, Gambusia affinis, or we can have the Poecilla reticulata. So these are some of the fishes available. These are the larvivorous fishes. Coming to the bacteria or the bacilli, which may be anti-larval. See, what happens is the larva would eat these bacilli and larva die. So what are the bacilli you need to remember? That is Bacillus thuringiensis or Bacillus sphaericus. So Bacillus thuringiensis is very commonly used. It is by the name of BTI-H14. And Bacillus sphaericus is also used. The use of Bacillus sphaericus is Culex quinquefasciatus predominantly, and for thuringiensis it is for Anopheles stephensi and Aedes aegypti. Aedes aegypti and Anopheles stephensi primarily by the BTI-H14, and Bacillus sphaericus is for Culex quinquefasciatus, and primarily Bacillus sphaericus is used in polluted waters. Polluted waters, as BTI-H14 is not used in polluted waters. So these are a couple of things you need to remember for the anti-larval measures. So now what we have covered is source reduction, personal protection, and anti-larvals also. We discussed about the physical, chemical, and biological methods. Coming to the next portion of anti-adult measures. Anti-adult measures. The anti-adult measures. Now you're going to kill a flying mosquito. How will you kill an adult mosquito? You slap him using bats or something. That you can do. You can even catch the mosquito with the hand. That also you can do. So anti-adult measures are all available. But Government of India National Vector-Borne Disease Control Program, they don't understand this clapping and the bats. So under anti-adult measures, we need to have some measures which are on population basis. The two MCQs which you need to remember, the two ways by which we can kill a flying mosquito is either use a spray or use another spray. So what is this two sprays I have written? Either use a space spray or use a residual spray So residual spray will have its residual action. Space spray will not have its residual action. This is what you fondly call as fogging. The fogging vehicle you must have seen in your life. That vehicle is there with a lot of smoke. That is a space spray. So coming to the point of a residual spray, if we talk about the residual spray, the chemicals which are allowable, which are approved by the Government of India, National Vector-Borne Disease, are only three chemicals: DDT, malathion and synthetic pyrethroids. DDT and malathion are the two most commonly used insecticide for residual sprays, IRS. We call this as IRS, insecticide residual spray. On the other hand, synthetic pyrethroids are there. See, there is a pyrethrum. You must have heard about pyrethrum. What is pyrethrum? Pyrethrum is a natural. It is a natural alkaloid. It is from a chrysanthemum flower extract. Now, chrysanthemum flower and pyrethrum, these are very effective and potent in insecticides, but it will take a lot of pyrethrum or a lot of chrysanthemum for us to do it on a country level. And of course, it is expensive, so therefore it is not used. We have a synthetic pyrethrum. We made our own synthetic pyrethroids. For example, just for your namesake, you don't need to memorize them: delta-methrin, cyfluthrin, alpha-cypermethrin, lambda-cyhalothrin, etofenprox, bifenthrin. All these are types of synthetic pyrethroids, right? So we have approved only three things, that is DDT, malathion and synthetic pyrethroids. A couple of questions on DDT. I know a lot of questions you must be having. Even in entomology, we talk a lot about DDT and its biomagnification effects. But DDT, you know that it's such a wonderful thing. Do you know that Dr. Paul Miller was the person who discovered DDT way back in 1943. And since then, we have been using DDT time and again. What is the full form of DDT? It is diphenyl trichloroethane. So we have been using DDT since long time. India is also a part. Now I'm telling you from the National Vector-Borne Disease Program control perspective. India is also a part. We are a party to the Stockholm Convention. What is the Stockholm Convention? That we will not use insecticides which may cause agricultural or human harm, and DDT is one of the insecticide. So we had to take a special permission from the WHO. They gave us a permission from the country level. I'm saying that we will not use more than 10,000 metric tons of DDT in 1 year in the whole country. Because we are under the Stockholm Convention, the Government of India is bound not to use DDT beyond this 10,000 metric tons. So therefore, what I'm trying to say is, I'm trying to justify the point that don't get confused that some people, some books, some authors are saying that DDT is out now. I'm saying that DDT is being used in certain areas with a certain limitation. Right? So of course, DDT is tried to be phased out now. Many areas they have already phased out DDT, but still many areas are still using DDT. So the limit that we have in India is not more than 10,000 metric tons. DDT and malathion both are being used as the insecticide of choice under the National Vector-Borne Disease Control Program. DDT is sprayed at the rate of 150 metric tons per million population. This is the requirement of DDT for 2 rounds. It is 150 metric tons for 2 rounds of DDT. And similarly for malathion, you can remember that we need 900 metric tons. That is the requirement per million population. Malathion is given for 900 metric tons. You require for 3 rounds of malathion. 3 rounds of malathion. Malathion would have a residual effect. It has a residual effect for approximately 6 to 8 weeks. And DDT has a residual effect for 12 to 15 weeks. That is from 3 to 5 months. It has a big amount of residual effect. And DDT is sprayed at the rate of, if you talk in terms of per square meter, it is sprayed at the rate of 1 gram per meter square. And malathion is sprayed at the rate of 2 grams per meter square. So this is what National Vector-Borne Disease Control Program has implemented in the whole country. Please remember that DDT, I know it's a insecticide which has hazardous effects, and that's the reason I'm saying you that India is a party of Stockholm Convention. We appreciate that, we regard that, and we have taken a special permission from WHO to use DDT, not because we want to use DDT, because of absence of any other effective insecticide of this particular level. DDT has a mosquito scary phenomenon also, that even if it doesn't kill the mosquito, still the mosquito doesn't even like to be in a place where DDT is there. So there are areas which are DDT sensitive and there are areas which are DDT resistant. Resistant areas we are spraying malathion. Coming to the other arm, so what we have discussed in anti-adult measures is we have talked about the residual sprays. Coming to the other arm of the space spray. So now talking of the space spray. Space spray is allowed using these chemicals, that is malathion, cyphenothrin and pyrethrum extract. Now pyrethrum extract is that's what we had already discussed, right? That it is from chrysanthemum flower. Pyrethrum extract has been approved only by National Vector-Borne Disease Control Program. We have approved pyrethrum only for indoor fogging. So in case there is indoor fogging within the hospital wards, within the houses, for those cases we are using pyrethrum fogging, because that will be required in minor quantities, small quantities, and it is of course a natural alkaloid, so the chances of getting any side effects would be very less. Malathion is to be sprayed with the fogging, this thing machine is there, right? You must have seen that big machine with the vehicle, and in that we put fogging, we put this chemical malathion at the rate of 50 ml in 1 liter of diesel. 1 liter of diesel. This is what is recommended. This is what is recommended by the Government of India, and cyphenothrin is used in the same amount of 70 ml per liter. We use it, and there's a lot of smoke. The problem with malathion and cyphenothrin would be the happening of smoke, and it may cause increased chance of respiratory problems in people who are more vulnerable. So with that, we have completed your whole system of the integrated vector management. Just a very quick recap slide which is going to help you in your exam. This will be a high yield table or a high yield slide for you. Integrated vector management, we have the source reduction, we can have the anti-larvals, anti-adult and personal protection measures. The source reduction, you already know about the Aedes mosquito, the Anopheles mosquito and the Culex mosquito, what all waters to be taken care. Anti-larvals, I talked to you about the physical methods, the chemical methods and the biological methods. Biologically, most commonly we are using BTI, that is Bacillus thuringiensis H14, and it is primarily for the Anopheles and the Aedes mosquito. We also can use the Gambusia fish. The most common chemical that we are using currently is Temifos, and the new chemicals are insecticide growth regulators, pyriproxyfen. Anti-adult measures, the anti-adult measures we already talked, we can have either indoor residual spray or we can have the outdoor space spray or the fogging, or we can have the indoor fogging. The indoor fogging is what is using the pyrethrum. The outdoor can be using malathion. Most commonly we are using malathion 50 ml in 1 liter, and IRS is either by DDT or by malathion. Personal protection is using the bed nets, and this is a very 5-star MCQ slide for you. Many times you get questions from this integrated vector management under the National Vector-Borne Disease Control Program strategy. So that completes our strategy number 4 about the integrated vector management. Now you are left with 2 strategies which are of main importance, 5 and 6. Before I can help you in discussing 5 and 6 strategies, that is about the case detections, I need to talk to you about the history of the program. So if you talk about the history of the program, initially in year 1953, we started with the National Malaria Control Program. Then slowly the things happened and we changed the program name to National Malaria Eradication Program. And then in 1971, we had the Urban Malaria Scheme. 1977, we had the Modified Plan of Operations. 1998, we had the Rollback Malaria. And 2004, today we stand at a point of National Vector-Borne Disease Control Program. So I don't want to scare you with the slide. I don't want to scare you with these numbers, with these dates. You don't need to memorize them. But there are certain MCQs over here which can be asked in the exam. MCQ number 1. Which is the oldest health program? Please mind it that 1947 India got independent, and the first health program, this is the first national health program that was formulated in our independent country, in our free India, was the National Malaria Control Program. So everybody was so happy with this, and we all, like not we, my seniors, we all worked for this national health program, that is the first oldest health program, with full zeal. MCQ can be asked, which of the following is the first health program? Mind it, this is the national first health program. The first program under the national ministry was the National Family Planning Program. National Family Planning Program was the first program. National Malaria Control Program was the first health control program or health prevention, disease prevention or health program. So National Malaria Control Program, everybody worked for it. Can you beat that? If I just tell you some numbers, even you'll get goosebumps. Can you beat that at that time, 1950s? How much people used to get malaria? It was 75 million cases in India were reported to have malaria in 1950. Can you beat this number? 75 million cases. How many COVID cases we have in the whole world? In the whole world, we have 40 million cases, 40 million. And in malaria only, in India only, we had 75 million cases. It was so bad. 22% of the Indian population was suffering from malaria at a given point of time. That is 1/5 of the country is getting malaria and people dying from malaria. It was immense. And today we are proud to say that approximately 3 to 4 lakh people only get malaria in 1 year. 2018 was around 4.5 lakh population. But anyways, all said and done, this could be an MCQ, that which is the first health program, National Malaria Program. And everybody worked for it very nicely, and slowly the malaria declined. India was one of the country which declined the malaria prevalence from 75 million cases and incidents, malaria incidents, 75 million cases to only 15 million cases within 3-4 years. So malaria, that tells you two things, that malaria is so sweet, it is so docile that you strike it, it gets down. You leave it, it comes back like anything. First thing. And second thing is that India got very happy. PSM people, they get very happy very fast. They get very sad very fast. So PSM guys, they got very happy very fast, and the name change happened from control to eradication, with forgetting little bit concepts in epidemiology where we had that elimination phase. Anyways, so National Malaria Eradication Program was started. And then in 1960s, there was a resurgence of malaria. 64 is called as the dark stage of malaria because there was a very high increase in number of cases. 9 to 10 million cases started coming every year, which was down to 5-6 million. So in 1971, we had urban malaria scheme. Most of the cases came from urban areas. Right? So we started with the urban malaria scheme, and then modified plan of operations, rollback malaria and vector-borne disease. Direct hardcore MCQs on this now. 1953 National Malaria Control Program. You need to do some of the strategies which will help you to formulate the current strategies which are being followed under the National Vector-Borne Disease Program. Under National Malaria Control Program, how was this program started? Listen to the words very carefully. Under this program, we thought that we will make a post called as malaria worker. We will call a post called as malaria worker. This malaria worker will go to everybody's house, knock the door and say that, Namaskar, I am from Health Department, Malaria Department, Health Ministry. Do you or anybody in your home have fever since last 14 days? So this is such a simple line, but in this line there are 5 MCQs. MCQ number 1, who will do this surveillance? Asha worker, Anganwadi worker, malaria worker, health worker. Answer is first MCQ, malaria worker. Next MCQ. Was it a door-to-door survey or a village-to-village survey or a district level survey or a state level survey? Answer is it is a house-to-house survey. Second MCQ. Third point. This survey was what? Was it a malaria surveillance or was it a fever surveillance? He said, Namaskar, that do you or anybody have what? Fever since last 14 days. So it was not malaria surveillance, it was a fever surveillance. Fourth point. This fever surveillance or this fever survey or this house-to-house survey or this malaria survey was conducted after how much time? What was the periodicity of this survey? See, this person had come and said that, Namaskar, do you or anybody in your house have fever since how many days? Since 14 days. That means this guy is going to come back after 14 days. So that means this was a fortnight survey system. So there was a fever surveillance conducted every 14 days, conducted by malaria worker for fever surveillance. And it was a house-to-house surveillance. Next point. In case the person said that, yes, I had fever, then this malaria worker will take out from his pocket 4 tablets of chloroquine. What will he take out? 4 tablets of chloroquine and give to that person and also make his blood examination for malaria testing. So that means what? This person had just said that I have fever, right? So that means there was presumptive chloroquine treatment given. To all cases of fever, we will give chloroquine until and unless proven otherwise. All cases of fever will get chloroquine today, right? So we'll get chloroquine on that date under this National Malaria Control Program. So these were a couple of your strategies. Alongside, we also started with the indoor residual spray in the whole country, spraying of DDT biannually in 2 rounds. So 2 rounds of DDT was started when? 1953 National Malaria Control Program. This surveillance system, what is this known as? Will it be called as active case surveillance or will it be called as a passive case surveillance? What do you want to say? This is called as active, where you go and search, or passive, where you're just sitting and people come to you. This is an active case surveillance. So this was your next strategy. We started with the ACD. Active case surveillance. So integrated vector management, we have already discussed that under this we had the IRS. So IRS was started when? IRS was started with the National Malaria Control Program. Anyways, moving forward, National Malaria Eradication Program, this all surveillance went and everybody was very happy. But then we started seeing a lot of cases. So what were the strategies under the 1971 Urban Malaria Scheme? Under 1971 Urban Malaria Scheme, because a lot of urban areas were started getting affected, we started with the drug delivery centers and fever treatment depots. We started with the drug delivery centers and the fever treatment depots. So what happened is, in urban areas, in every hospital, in most of the hospitals, there will be one doctor who will be called as a malaria doctor, and it's his job that any patient who comes with fever has to pass through that malaria clinic. So setting up of malaria clinic was what was the main strategy under the urban malaria scheme. Malaria clinics in the area were set up under the urban malaria scheme. So that is your point number 2. Malaria clinics. Now, what is this malaria clinics? What do you think? This is actively going to the population and doing active case surveillance, or the population will come to us and we do passive case surveillance? So absolutely correct. I think you all have got. We started with the PCD. So this can be MCQ. ACD was started in 1953 with the first level program. PCD was started in 1971 with urban malaria scheme. That is what my whole intention of discussing the history with you was, that we are doing 2 types of case surveillance. We have an active case surveillance, active case detection system, even hanging on today, and we also have a passive case detection system, even hanging on today. So these were your couple of things which you need to remember. Next, still we did not get very nice results, but still 1976, again, the country got resurgence of malaria. Around 7 to 8 million cases came in 1976. So government said, wait, you need to stop. go back to the drawing board and see where we are doing wrong. So you have a program which did so marvelously in 1953 to 58. That was a golden period. And then it went drop down. And again, you start get resurgence of cases. So we had to rethink and go back to the drawing board. So what we did was we divided the whole country. The efforts of malaria were dependent on API less than 2 and API more than 2. This is also of importance because currently today this API has changed criteria from not less than 2 and more than 2. We now have API less than 1 and more than 1. Okay, so anyways, please remember that under the modified plan of operations, we divided the country into API less than 2 and more than 2. 1998, you just have to remember 2 points in this. Rollback malaria, we got WHO funding. And newer insecticides were launched. Newer insecticides were launched under this program, and that is the reason we don't use a lot of Paris green or other older insecticides. We now have Temifos and newer insecticides into the system. And 2004, we now have an integrated approach where we are tackling malaria, dengue, kala-azar, Japanese encephalitis, lymphatic filariasis, chikungunya all at a single time, because this program has an integrated approach. So coming back to your strategies, you have early diagnosis, prompt treatment, chemoprophylaxis, integrated vector management, active case detection, passive case detection, and API based strategies. So all are API based, annual parasite incidence based strategy. The last is tribal malaria action plan. So tribal malaria action plan is just to have, because currently I'm telling you around 3 to 4 lakh cases occur in the whole country. So that is 0.3 million cases, but still 0.3 million cases do come in our country. Out of these 0.3 million cases, do you know that 50% of the cases, more than in fact 50% of the cases are only from the tribal areas. So tribal areas are now becoming the high focus points, because if you want to decrease the malaria in the country, you have to focus on the tribal areas. So tribal malaria action plan has been built up. Tribal malaria action plan has been built up. Under this tribal malaria action plan, we are actually integrating all the integrated vector management, enhanced case surveillance, and all these things under the tribal malaria action plan. So just remember that tribal is areas are more focus into more focus nowadays. So that is all about the active case detection and the passive case detection under the National Vector-Borne Control Program strategies. That completes our strategies for this program. Next is, let's have a look at the organization of the National Vector-Borne Disease Control Program. Organization, just 2 MCQs. That's so easy. 2 MCQs. First MCQ, that this program, is it run under the National Health Mission or is it under the direct Health Ministry? It is directly under the center. So it is a centrally run scheme. It is one of the oldest program, and the people are still conventionally made to work from the center ministry only. So it is a centrally run program, of course, with attachments from the National Health Mission and so on and so forth. But however, the regular posts under this National Vector-Borne Disease Control Program are still under the center ministry. Second point that you need to remember for your exam is that what is the hierarchy. So nothing very special at the center level, then comes the state level, and then comes the district level. So at the center, you have the NPO, that is National Program Officer. National Program Officer. At the state level, you have the State Program Officer. At the district level, you have the District Program Officer. 1 MCQ over here, that along with the DPO, that is DHO, we also call that as DHO, District Health Officer, or the District Program Officer under the program National Vector-Borne Program. We also have another post in the cities called as the AMO. AMO stands for Assistant Malaria Officer. Now in the whole country, Assistant Malaria Officer, that is the AMOs, they are available in all the cities and the towns, and they are the main people who are implementing the program at the country level. So implementation and monitoring evaluation takes place at what level? District level. Who is the main implementing person? It is the anti-malaria officer. Next MCQ, just for you to know that how do we classify the states in our country based on on annual parasite incidence based on the API. So the states can be classified into category 3, 2, 1 and 0. So when will we call a category 3 state? We will call the category 3 state if the API of the state is more than 1. So mind you, in the modified plan of operations, we had API less than or more than 2. So now we call a category 3 stage if the API is more than 1. So if the API is more than 1, that will be called as intensified malaria control state. So you need to do a lot of work over there, that is intensified malaria control state. In category 2, the API is less than 1 of the state, but some districts report API more than 1. Some districts will have more than 1. So now this is a problem that overall state is less than 1. This is known as a pre-elimination state. They are about to eliminate, but they need to work more. Now in the third level, if the API of the state is less than 1 and all districts in the state, they also report less than 1. This phase is known as elimination phase. Don't confuse this with the level of malaria elimination. We say that an area is malaria eliminated area if there is no case found since 3 years. That is separate definition. This is state level categorization of the states based on the API. We call these states as elimination level states, pre-elimination states or intensified malaria control states. If the API of the state is less than 1, that means if the API of the state is 0, that is no API, that is no malaria case. Of course, there is no in the district. So now in this area, this is technically a malaria free area, but we don't call it as malaria free because we don't have the certificate yet. We call it as prevention of resurgence state or prevention of re-establishment state. It is called as prevention of re-establishment. It's a technically correct word, re-establishment, or just if you want to remember, it means resurgence. You want to prevent the resurgence of malaria in that state. That is called as prevention of resurgence of re-establishment. So for your MCQ exam, please remember intensified malaria control, pre-elimination, elimination area, or a prevention of re-establishment phase. So all these are based on API. Please remember, I'm telling you again in your exam, don't get confused if I say you ABER or child spleen rate or the infection parasite rate. It is based on what? It is based on annual parasite incidence only. The state division in our country. Next is WHO has its own problem. WHO is world problem, World Health Organization. So WHO is a World Health Organization. It has to cater for Africa, for Asia, for Europe, for developed nations, for South America, where a lot of malaria is already there. So many states or many partner countries, they do not have the access to annual parasite incidence. Their data is not so much updated. But yes, they do have the data for the child spleen rate. So for international surveillance, we take watch of API. We take watch of ABER for international malaria surveillance, and we also take watch of the child spleen rate. So child spleen rate, based on the child spleen rate, many countries will be divided who lack the data for API. So you need to know what is a child spleen rate. So child spleen rate, that is a child spleen rate. It technically means a number of children who have splenomegaly. So child spleen rate is for assessment of surveillance for children. What age group? 0 to 2 years, 0 to 5 years, 0 to 1 year, 5 to 10 years. What do you want? Answer is MCQ 2 to 10 years. It is from 2 to 10 year children. So if the child spleen rate, number of people having splenomegaly, number of children having splenomegaly is less than 10%, that is good. That is known as non-endemic zones. If it is less than 10%, but if it is more than 10%, that is known as problem zones. So 10 to 25, 25 to 40, more than 40. 25 to 40 is what is called as endemic area. 10 to 25 is hypoendemic, and more than 40 is hyperendemic area. Hypoendemic and hyperendemic areas is what is more than 10%. So please remember the cutoff for the child spleen rate we take is is 10%. It is one of the field indicators, specifically in countries which do not, which lack the data for annual parasite incidence. So of course, we'll be talking much more in detail about all the indicators, that is annual parasite incidence, annual blood examination rates, the slide positivity rates in our next module when we talk of all the indicators as a single place. But this was just for you to sensitize you that these all indicators are used to divide the strategies or to make the strategies in these particular areas. Thank you so much for watching this module. See you in the next video.